Hello everyone, welcome back. Hope you are doing good. So in this session we are going to talk about how to solve a case scenario or how to approach a case scenario, okay? So because case scenarios, they are going to be a large part of your MCQs from now on. So solving in case scenario is going to take your time. So if you can calculate your time per question approximately 45 seconds, okay? Where you can save the time in simple one-liners. So in simple one-liners, you read the question fast, you answer, you save your time for case scenarios, okay? Okay, now you see this much big question case scenario. What is the first thing that should come to your mind is you have to approach or you have to see absolute positives and absolute negatives, okay? So I'm just reading the question out for you. A 52-year-old male patient reports to your clinic with the chief complaint of difficulty chewing and dissatisfaction with removable partial denture. He is medically healthy, a non-smoker and maintains good oral hygiene. So clinical and radiographic examination revealed a missing mandibular right first molar 4.6 with adequate bone height but reduced buccolingual width of 4.5 mm. The opposing maxillary first molar is present and is normal occlusion. The patient is interested in a fixed solution and asks about implant. Okay, so when I read this question, the first thing that should come to my mind is what is the absolute positive I am going to take from this question and what is the absolute negative, okay? So if you ask me any case scenario you see, you just come to the last line, okay? Whenever you come to the last line, this will indicate the diagnosis and what you're looking for. So I'm going to look something related to implants, okay? And I'm going to mark the absolute positives, okay? So the absolute positives will be there is good adequate bone height, okay? The height is good. The opposing maxillary tooth is present and it is in normal occlusion. These 2 points will be absolute positives for me. Now I am going to see what is absolute negatives. So in this question, the absolute negatives will be there's going to be missing mandibular right first molar and also there's going to be reduced buccolingual width. These 2 points, this is going to be absolute negatives for me. Okay, now when you see a case scenario and you marked out absolute positive, absolute negatives and you're going to come or you're going to find out what is the diagnosis, you have to rule out the absolutely zero chance of becoming right option, okay? So in this question, patient asks about implants, patient inquires about implants, I'm taking x-rays, I'm seeing clinically there is good height but less buccolingual width. So this talk something about implants, okay? So let us look at the last option. So suggest a cantilever bridge using adjacent teeth. Okay, patient is asking about implants. The last MCQ is something a fixed partial denture, FPD. So I'm going to take support from 4.7 or 4.5 and I'm going to give cantilever to 4.6. You know what is cantilever, right? So support from one tooth and the other tooth is hanging. Okay, so 4.7 will be crown, attached to that will be 4.6 hanging. That is called as cantilever. Okay, so this is completely irrelevant to my question. I'm not going to talk about fixed partial denture now. Patient is asking about implants. There's no need to explain about a cantilever especially. Okay, so I'm going to rule out D option. What is left out? I'm going to read the 3 options and I'm going to eliminate as much as I can. Okay, so say example, place a standard diameter implant without grafting. Okay, so let me tell you what are the various diameters of implants available. Okay, so before moving, I'd like to tell you one thing. When you read or when you refer something, you refer it from a standard textbooks. Don't refer from a random article. The random article will not have that much evidence for you. Okay, when you refer a good textbook, I'm going to talk about MISH. MISH is an excellent textbook for implants. What I'm going to tell is from MISH. So it's a little bit evidence based. Okay, okay. Now the diameter of implants. The first one will be smaller diameter. Okay, smaller diameter or what we call it as mini implants, 1.8 to 2.9 mm. Okay, before moving, what is the diameter of implant? See, say for example, you see an implant like this. Okay, this is, I'm seeing it from the side way. Okay, this is the length of the implant. Okay, so when I take an implant and turn it towards me, it will be something like this, right? So this is the diameter. Okay, so the diameter, if it is 1.8 to 2.9, it's a smaller diameter or mini implants, orthodontic anchorages. Narrow diameter implants. Narrow diameter implants ranges between 3 to 3.5 mm. You can use it for mandibular anteriors and maxillary laterals. Okay. Next is standard diameter implants. Standard diameter implants will be 3.5 to 4.2 mm. You can use it in maxillary anteriors and also premolars. Wider diameter implants ranges between 4.5 to 6 mm. This is suggestive of placing an implants in molars. See, clinical, using implementing in clinics is different from theory. If you ask me in clinic, I will say that 1 mm of buccolingual width is enough to place an implant. But I cannot go and justify this in NEET, especially when you are asked a question, an accurate answer is required, right? So you have to just not tell absurd answers. You have to tell that with evidence, okay? So when I talk about wider implants, it's 4.5 to 6 mm. When I say that it is indicated in molars, it is indicated in molars according to Mish. Okay, so you can use this in molars. And there is something called as extra wider implants. Extra wider diameter implants are more than 6 mm. This is usually indicated in case of patients who are going for immediate implants, especially mandibular molars or maxillary molars, immediate implants, or when you augment an bone, augment the ridge, and then you place an implant. Okay, so these are all the various diameters. Okay, so and also there is a set of rules you must be aware of it. So when I place an implant adjacent to the tooth, there should be minimum of 1.5 mm. Implant to implant distance should be 3 mm. Okay, implant to vital structures, sinus, nerves, 2 mm. Implant should be 1 to 2 mm apical to the adjacent CEJ. Apical to adjacent CEJ. Adjacent to CEJ, it should be apical. Implant should be placed 1 mm below the buccal bone crest for aesthetic emergence. Implant should be placed more palatally in aesthetic areas. Implant should be placed palatally in aesthetic areas. An implant, it should be placed parallel to the adjacent tooth. And very important thing, the bone to width rule. Okay, the bone to width rule is 2 mm of bone buccally and 1 mm of bone lingually should be present. In simple words, implant diameter plus 3 mm. This should be the bone width rule. So implant diameter, say for example 4 mm of implant I am placing, there should be 7 mm of buccolingual width to place a 4 mm diameter implant. 5 mm diameter implant I am placing, there should be 8 mm of buccolingual width to place an implant. So 2 buccally, 1 lingually. This is the bone to width implant ratio. Okay. So now you know this information, you are going to solve this MCQ. So now you are going to tell me, I am going to place a standard implant diameter of 4.3 mm without grafting. So what is the available bone height? 4.5. So when I am having a bone of 4.5 and I am placing an implant of 4.3 mm, am I going to have sufficient buccolingual width? Obviously no. So what will happen when I place an implant in this bone, a 4.3 mm implant? If I place an implant, what is going to happen? Obviously there is going to be thread exposure. The implant, a few threads of the implant is going to get exposed. Okay, and what if I don't place a bone graft or a membrane and suture it? There is obviously going to be peri-implantitis. So I am placing a standard diameter implant that is acceptable to some point, but without grafting, with this buccolingual, this is not advisable because a few thread is going to get exposed and that is going to result in peri-implantitis. So I am going to rule out the first option. Okay, so I am going to rule out the first option. Why? Because some threads is going to get exposed. 4.3 mm diameter in a 4.5 mm ridge is insufficient. Okay, next, place a narrow diameter implant, the first line itself, it gets ruled out. I'm not going to place a narrow diameter implant. Where I'm going to place a narrow diameter implant? Probably in mandibular, maxillary anteriors or in mandibular anteriors. Okay. Especially when you are loading or when you're placing an implant in posteriors, you always prefer an wider implants according to mesh. Okay, why? Because the wider implants, when I go for wider implants, there's going to be more amount of implant diameter, there's going to be more amount of stress distribution. So when I go into load, I'm going to distribute the forces equally. When I place a narrow diameter implant in a molar region, there's not going to be proper force distribution, and probably that might result in future peri-implantitis. Okay, so I'm going to rule out this option, narrow diameter implant, no, and that too immediate loading, never. Okay, immediate loading depends upon a lot of things. It depends upon primary stability, the bone density, and few other factors. So I'm not going to talk about that. So I'm going to rule out option B because I'm not going to place a narrow diameter implant in molar region. Okay, so standard diameter implant, yes, of course I can place, but not without grafting because there's going to be insufficient buccolingual width. Then comes the ridge augmentation before placing the standard diameter implant. Yes, so I'm going to augment the ridge buccolingually, and then I have to wait for, say for example, 4 to 6 months or probably 1 year, and then I'm going to place an implant. So there are a set of rules for buccolingual width ridge augmentation. Okay, so the first rule will be if the bone width is less than 5 mm buccolingually, knife edge ridge. Okay, and then post-extraction collapse. Okay, a patient extract the tooth, goes home without replacing the tooth. 1 year, almost 50% of the bone will be lost. Post-extraction collapse. Prior implant failure. So these are all the few situations where I am going to do a buccolingual augmentation. Now you are going to tell me whether this augmentation is called as GBR or GTR. It's obviously GBR, right? So what is GBR? GBR is guided bone regeneration. What is the difference between GBR and GTR is, when I try to augment a bone in an edentulous site, here 4-6 is missing. When I'm going to augment 4-6 where the tooth is not present, I'm going to call that as guided bone regeneration. I want only bone cells to migrate there. Whereas when I want to regenerate an area where the tooth is present, 3-wall defect, narrow 2-wall defects, where I'm going to place a bone graft and membrane, I'm going to suture it, that becomes GTR, guided tissue regeneration. I want specific cells to migrate into that area. Okay, there is a difference between GBR and GTR. Okay, so with this, you'll get a general idea of how to approach a case scenario. Okay, so true or absolute positives, absolute negatives, the last line, and then you have to rule out absolutely irrelevant information. Then you have to scrutinize it based on the information you have. So how to make, initially it might be very difficult to solve a case scenario. So how to master is, you have to solve case scenarios as much as you can whenever possible. Wherever you see a case scenario, just solve it. Even if you don't have enough information, okay, fine, no issues, you solve it, then read the explanation part. Okay, so thank you so much for watching the video. Have a great day.